It's 8 o'clock in the morning, so welcome everyone to our weekly transplant grand rounds. Today it is my pleasure to introduce our speaker, Dr. David Newland. David, as you guys know, is our current PGY2 solid organ transplant pharmacy resident. David completed his Bachelor's of Science in Pharmacy degrees at Indiana University in biology and neuroscience. He completed his master's degree at Purdue University in Indiana. He went on to complete his Doctor of Pharmacy degree at Pacific University in Oregon, in Oregon. Right. And he completed his PGY1 pharmacy residency at the Seattle VA. So today, he's going to talk to us about his PGY2 residency project. And as you guys have heard us say before, our residents, as part of their residency requirements to get their certificate, must complete a major project. Most of our residents do a retrospective chart review. David, you'll notice, is a little bit more enthusiastic than that. He has a lot of energy, and so he decided to take on a rather daunting project this year of implementing a pilot clinic for our post-transplant patients and managing their diabetes. Two of David's passions are taking care of transplant patients and taking care of patients with diabetes. So this was the perfect project for him. So today he's going to present his interim results on his project. So please welcome Dr. Newland.
Awesome. Thank you for the awesome intro, Pam. I appreciate that. You guys excited to talk about diabetes today? Because I am. All right. Here we are. I have nothing to disclose. So by the end of today's presentation, I want for everyone to understand the significance of post-transplant diabetes in our solid organ transplant recipients. Also, we're going to outline the key steps in implementing a pharmacist-managed post-transplant diabetes clinic. And lastly, we're going to discuss the key interventions that have been made during the intervention period thus far. So we're going to move on and discuss background. So in addition to the risk factors for type 2 diabetes that we're all familiar with, we give a patient a solid organ transplant, a gift of life, and with that gift comes a risk of developing diabetes. And this majorly is due to the immunosuppressants we give the patients. So our calcineurin inhibitors, tacrolimus and cyclosporin, for example. Tacrolimus has a greater diabetogenic effect than cyclosporin does. Also, corticosteroids. Patients who are Hep C seropositive, also patients who have CMV infection, and also who gain weight post-transplant are at an increased risk for post-transplant diabetes. So we're going to start off with a question. So the diabetogenicity of the calcineurin inhibitors occurs through which mechanism or mechanisms? Is it A, pancreatic beta cell toxicity, B, insulin resistance, C, both A and B, or do we just not know? Who thinks it's A? Who thinks it's B? Okay, C? All right, who thinks we just don't know? All right, we'll get into that. So calcineurin is an enzyme that is ubiquitous in the majority of our tissues. And so it has a normal homeostatic function that when it's inhibited, it throws off this homeostatic balance, and which can account for the majority of the adverse events that we know are associated with the calcineurin inhibitors. One of the functions of calcineurin is actually in the islet cells of the pancreas. And so what it does is it actually will control apoptosis of these cells. And so if calcineurin is inhibited, what happens is the cells will undergo apoptosis, and then you get the subsequent decrease in insulin secretion, and this is one mechanism of developing diabetes after a transplant. Now, also, calcineurin is it's implicated in gene expression at the level of the muscle tissue, and so this can actually induce insulin resistance. So what calcineurin is composed of is three main subunits. We've got calcium calmodulin, we've got calcineurin A, and we also have calcineurin B. So this functions as a phosphatase. What it does is it's going to dephosphorylate NFAT, which stands for nuclear factor of activated T cell. What happens is NFAT is dephosphorylated. It translocates inside the nucleus of the cell. And inside the nucleus of the cell, it is responsible for the transcription of type 1 or slow muscle fibers. And these slow muscle fibers are insulin sensitive. Now what happens is when you inhibit calcineurin, you get this gene switching such that you get a switch to the transcription of type 2 or fast twitch muscle fibers, which are insulin resistant. So this is really important for us from a pharmacological standpoint because this helps us better understand how we could tailor therapy to counteract this mechanism. And also keep in mind that 70 to 80% of the glucose from a meal is taken up by our muscle cells. And so if our muscle cells aren't able to use the insulin, then we're going to have this hyperglycemia. So the answer is both A and B. Good job, guys. All right, question 2. The diabetogenicity of corticosteroids occurs through which mechanisms? Or mechanism? So it's going to be A, pancreatic beta cell toxicity, insulin resistance, both A and B, or we really don't know. Who thinks it's A? B? C? Both A and B? Who thinks we just don't know? Okay, so this is actually, the mechanism is actually fairly well understood. So what happens with steroid diabetes, you get our corticosteroids that can actually go and act directly on the islet cells. So we've got a similar mechanism. We've got the endoplasmic reticulum stress induced on the pancreatic beta cells. So you get this similar decrease in insulin secretion. But then you have the stimulation of pancreatic alpha cells to release glucagon. The glucagon is then going to go to the liver, and it's going to stimulate gluconeogenesis. And what happens is you're getting this formation of glucose molecules, and then you also have the stimulation of glycogenolysis. So you're trying to store glucose, but then you're breaking down the glucose that you have stored in the form of glycogen polymers, and that is being spit out into the bloodstream, ultimately increasing blood glucose levels. Also, corticosteroids can inhibit the effect of GLP-1. GLP-1 has a protective effect on our pancreatic beta cells. So GLP-1 can actually maintain and prevent or it can maintain pancreatic beta cell function. And then lastly, the level of skeletal muscle, the corticosteroids can induce insulin resistance, whereby the insulin receptors do not recognize insulin as well. So the answer is both A and B. All right, our third question here. The diabetogenicity of the hepatitis C virus primarily occurs through which mechanism or mechanisms? Is it going to be pancreatic beta cell toxicity? Is it going to be insulin resistance? Is it going to be both A and B? Or is this something we really don't know? So who thinks it's A? Who thinks it's B? Who thinks it's C, both A and B? And who thinks we just don't know? Okay. Actually, the diabetogenic action of hepatitis C virus is actually primarily implicated in insulin resistance. Again, this is very important. This helps us understand this pathophysiology and how we can target this from a pharmacological perspective. What happens is you get activation of T helper 1 type lymphocytes. You get the secretion of interferon gamma. This interferon gamma is going to stimulate the production of TNF alpha from macrophages. And this TNF alpha is primarily implicated in inducing this insulin resistance. The TNF alpha system is also causing the formation of fibrotic tissue at the level of the liver as well. On the other side, we've got the hep C virus causing fatty liver. This fatty liver can further cause insulin resistance, and it can also further cause liver fibrosis. Now, what this does is it creates a state of hyperinsulinemia, and this hyperinsulinemia will cause the upregulation of connective tissue growth factor, and also stellate cells will start laying down extracellular matrix. This is a perfect combination for laying down fibrotic tissue. Now, all this taken together can lead to type 2 diabetes in our patients who have hepatitis C virus. So the answer is actually B, insulin resistance. All right, so now we're going to move on and we're going to discuss the recent guidelines. So a year ago, this month, there are guidelines that were released where researchers from all over the world got together to discuss what are the best practices in diabetes management in our solid organ transplant recipients today. The first thing they did was they made a name change. We all loved NODAT, new onset diabetes after transplantation. They changed the name back to post-transplant diabetes mellitus. I was bummed out about that. I don't know about you guys, but I love saying NODAT. So that was their first recommendation. The other recommendations are going to center around time since transplant. So really, the first phase I'm going to talk about is going to be the first 45 days post-transplant, and then the second phase is going to be beyond that 45 days post-transplant. So one of the recommendations is that we do not diagnose our patients with post-transplant diabetes mellitus within the first 45 days post-transplant because of the effect of the various moving parts post-transplant. We have patients who are at risk for infections. We know infections are associated with hyperglycemia. We're giving our patients high-dose corticosteroids, and we're tapering them down in the immediate post-transplant phase. So what they suggest is, hey, let's give our patients about 45 days to reach their new norm. Let's get them down to their maintenance corticosteroid, or their maintenance dose of 5 milligrams of prednisone, for example. Then we can diagnose our solid organ transplant recipients with post-transplant diabetes, primarily using the oral glucose tolerance test, because this is deemed the gold standard for diagnosing post-transplant diabetes in our solid organ transplant recipients. Now, if that's not available, they suggest using fasting blood glucose or a random blood glucose per 2015 ADA criteria for diagnosing diabetes. They caution against the use of the hemoglobin A1C within the first 365 days post-transplant period because of the potential for skewing the A1C from pre or post-transplant anemia. Patients who are on dialysis, the receipt of blood transfusions, for example, can possibly skew the A1C. So what they suggest is, after 365 days post-transplant, they suggest, okay, again, oral glucose tolerance test, this is the gold standard, but then we can consider using our A1C as an indicator of glycemic control for our transplant recipients. And if that's not available, then we could use the fasting blood glucose or random blood glucose. Lastly, regarding the management, they recommend that in the first 7 days post-transplant, we use insulin solely to manage our patient's hyperglycemia. This is really important because what is thought is that using insulin in this first week post-transplant can help prevent the progression to post-transplant diabetes for some patients, because if you think about it, we're blasting the pancreas with calcineurin inhibitors that patients have been exposed to, high-dose corticosteroids. And what this can do is this can kind of help the pancreas out a bit. So they recommend using insulin in the first 7 days. Then we can progress to our non-insulin agents if needed. Now, after 45 days post-transplant, what is recommended is we can then use the similar management in the general population, where we would emphasize diet and lifestyle modification, then progress to our non-insulin agents, and then we could use insulin if needed. So now we're going to move on and discuss the epidemiology pre- and post-transplant incidence of diabetes. So per SRTR data, about a third of all of our kidney transplant recipients have a diagnosis of diabetes going into transplant. And as many of you may know, this is very important because diabetes is the leading cause of end-stage renal disease leading to the need for a kidney transplant. And about a quarter of all of our liver transplant recipients have a diagnosis of diabetes going into transplant. Post-transplant, about 90% of all of our kidney transplant recipients have or experience post-transplant hyperglycemia, which is exactly why we shouldn't be diagnosing patients in the immediate post-transplant phase, because nearly all of our patients would be diagnosed with post-transplant diabetes. So about 10 to 20% of our kidney transplant recipients will receive a new diagnosis of post-transplant diabetes within about 6 months post-transplant, and that incidence will increase about 6% annually thereafter. Now, I know this 10 to 20% seems a little lower, but keep in mind, that's in addition to the 30% I already reported on. So about a quarter of all liver transplant recipients and about 40% of our heart transplant recipients will receive a new diagnosis of post-transplant diabetes. And about 15% after 1 year and about 40% after 5 years of our lung transplant recipients will receive a new diagnosis of post-transplant diabetes. So why is this a big deal? This is very important because post-transplant diabetes is an independent risk factor for infections, for increased cardiovascular risk. Also, it's an independent risk factor for graft failure and death with a functioning graft. What I want to emphasize here is that we've got our short-term outcomes. Our 1 year graft survival is up to 95% for our kidney transplant recipients. And we've got our biopsy-proven acute rejection rates down to about 10% for our kidney transplant recipients. Those are excellent. What we need to focus on are long-term outcomes, our 5, 10-plus year long-term outcomes, because what is happening is that patients are dying with a functioning graft due to cardiovascular disease. So we need to be focusing on these ambulatory care issues, including post-transplant diabetes. All this taken together can lead to frequent emergency department visits and urgent care visits, hospitalizations, which can be costly to the health system. So with that being said, what I want to do is talk about a couple of the agents that can help counteract the pathophysiology of the diabetogenic factors I was speaking of earlier. So the GLP-1 receptor agonists, such as Byetta or exenatide, Victoza or liraglutide, what they could do is maintain pancreatic beta cell function. They also can delay gastric emptying. So this could be a benefit for some patients who might need to lose weight, but others who we don't want to lose weight, this could be a bit of a disadvantage. Now, the GLP-1 receptor agonists do have a black box warning for thyroid cancer, so it's something that needs to be taken into consideration. Now, this wasn't just rodents only. They are very costly. They can cause pancreatitis, possibly. Nausea is going to be the biggest limiting effect, unfortunately, with the GLP-1 receptor agonists. Most of the patients that I have had on GLP-1 receptor agonists have experienced nausea. Next, with our biguanidine or metformin we have available, this can decrease hepatic glucose production and also act as an insulin sensitizer. So it can help tell our muscle cells in the periphery to better recognize insulin and take up the glucose whenever after we eat a meal, for example. And so, of course, metformin, black box warning for lactic acidosis is what we're all concerned about, especially in our kidney transplant recipients, or in our other solid organ transplant recipients, that is. So we have to use caution with renal or hepatic dysfunction. Lactic acid is cleared through the liver, so we have to look at their liver function. Also, metformin is cleared renally, so we want to make sure that the renal function is good or at least not too compromised. So again, you have to look at the whole clinical picture of the patient. Metformin is cheap, which is good. TZDs have fallen out of favor. They do decrease hepatic glucose production, and they are insulin sensitizers as well. However, they do carry a black box warning for heart failure. Also, they can cause fluid retention, which is one of the reasons why it can result in heart failure. It can also they can result in ischemic cardiovascular events, and that's primarily with rosiglitazone. We've got hepatotoxicity, fractures, bladder cancer. Again, risks that we have to outweigh with the benefits. And lastly, we've got our DPP-4 inhibitors. With the DPP-4 inhibitors, such as Januvia or sitagliptin, what they do is they're going to inhibit the breakdown of GLP-1. So again, GLP-1 can have a protective effect on the pancreas or the pancreatic beta cells. So we want to make sure that, again, we're using agents that can help counter the pathophysiology I was just speaking of. So what's missing right now? Well, one, the agents that I just discussed being studied in the solid organ transplant population, most studies exclude solid organ transplant recipients. So what I'm getting at is the data is lacking. The last recommendation from the consensus statement that I was just speaking of is that we get out and we start conducting studies in our solid organ transplant recipients with regards to diabetes management, because there's not a lot of data out there, unfortunately. So we know that transplant recipients will oftentimes report to their transplant providers for diabetes care. And we do have some pretty good evidence of pharmacist-managed diabetes in the general population. However, this has not been demonstrated in the transplant population. So this leads me to the hypothesis of our study, which is that a pharmacist-managed post-transplant diabetes clinic can positively impact glycemic control in solid organ transplant recipients. The purpose of this study is to establish a pilot pharmacist-run post-transplant diabetes clinic, measure the impact of the clinical pharmacy interventions that I've made within the intervention period, and lastly, contribute to that positive data I was just speaking of. The way I first got this clinic implemented was I had to write up a proposal, present it to the Residency Advisory Committee, got it approved, and then I had a 4-week dedicated rotation in the transplant clinic to get patients enrolled. And this has actually been continued as a longitudinal rotation thereafter. Now, this has required a vast deal of logistical planning. I have been I've been very lucky enough to have an office to use. Patricia Jones was very, very, very gracious and let me use her director's office in the clinic, which is great. So that helped. I would see patients during their normally scheduled clinic visits. I would schedule visits outside of the clinic as well, too, as needed. And also have a specialty pharmacy that would deliver diabetes testing supplies to me when needed. Also, they would complete the prior authorizations for the GLP-1 receptor agonist, for example, which is very, very helpful. One of my favorite parts about this project was educating not only the providers, coordinators, or dietitian, our nurses, for example, that pharmacists can manage diabetes, but also educating our patients that their transplant pharmacists can manage their diabetes. And also, I created a protocol that I use in managing diabetes for my patients. So now we're going to move on and discuss methods of the study. So this is a single-center perspective observational study, which includes all solid organ transplant recipients who are greater than 18 years of age with a diagnosis of post-transplant hyperglycemia or post-transplant diabetes, who've been enrolled in the post-transplant diabetes clinic from January 1st, 2015 to June 30th, 2015. Those patients with type 1 diabetes or who are managed by an insulin pump have been excluded from the study. The way I first got patients enrolled in the clinic, I would peruse the clinic list the evening before and the morning of provider or of their transplant clinic visits, and I would identify those patients who had an elevated A1C or elevated fasting blood glucose levels. And what I would do is I'd go to their room while they're waiting to see the provider, and I'd introduce myself, and I would explain the risk of post-transplant diabetes, the benefit of enrollment in clinic, and that's actually how I first recognized patients or identified patients. Then I started getting consults from providers. PA Samuels, for example, and PA Dedman were contacting me, which was awesome because I was able to get patients enrolled, and that was one way that I was able to identify patients again. And of course, patients who are admitted to our floor for diabetes complications were on my radar. I'd also go get them admitted as well. I contacted patients myself, and this did require a flexible schedule. I do have a patient who was virtually non-compliant with his clinic visits, with his diabetes visits outside of clinic, and he's the primary breadwinner of his family. He, taking one day off work means losing money, and so I had offered to stay in the evening, and actually, Elvia and myself stayed. We actually met with this guy at 7 o'clock and met with him until about 9 p.m. He came with his family, with his 2 children and his wife, and that was one of the ways we were actually flexible for this patient. So now we're going to move on and discuss the primary outcomes addressed in the study. So these are changes in glycemic control at 3 months, specifically changes in hemoglobin A1C and also average daily self-monitored blood glucose. So for my patients who are on insulin, I would ask them to check their blood glucose 4 times a day, before meals and at least once 2 hours after their largest carbohydrate-rich meal of the day. And then for patients who are on just oral agents, for example, or just on non-insulin agents, I would ask them to at least measure their blood glucose twice a day, fasting, and then 2 hours after their largest carbohydrate-rich meal of the day. Secondary outcomes addressed are average fasting and 2-hour postprandial blood glucose, also body mass index, incidence of hypoglycemia within the last 7 days. This is compared from baseline to their last follow-up visit with me, and also incidence of diabetes-related hospitalizations within the last 90 days compared from baseline to the last follow-up day with me, and also medication-related interventions that took place. So again, what I'm about to present to you are the preliminary results of my study. The actual conclusion date is going to be June 30th. So I've got 35 of our patients here at University Transplant, at our transplant center, enrolled in the clinic. And so about half of them are kidney transplant recipients, about a third are liver transplant recipients, and the rest are lung transplant recipients. So the average age is 56 years, about 60% are male, and a little more than half of them are of Hispanic ethnicity. So of the 35 patients enrolled in the clinic, 5 of those patients were enrolled in my clinic within 45 days post-transplant. Now, of the 30 patients who were enrolled who were more than 45 days post-transplant, 12 of them had a diagnosis of diabetes going into transplant, and 18 had a diagnosis of diabetes after transplant. Now, of these 5 patients, 2 of these patients had diabetes going into transplant, and 3 of these patients did not have a diagnosis of diabetes going into transplant. So at baseline, the average A1C is 9.8% for all of the patients who had an A1C greater than 45%, or 45 days, and also for those patients in whom I had an A1C available for. Now, for those patients who had an A1C that was greater than their goal of less than 7%, their mean A1C was 10.6% with a range of 7.2 to 14.6. And the average daily self-monitored blood glucose levels for the patients is 209 milligrams per deciliter with a range of 114 to 468. So the mean BMI is 29 with a range of 19 to 50. There were 6 patients hospitalized with diabetes complications within the last 90 days. 3 of those patients were hospitalized for hypoglycemia, 2 were hospitalized for DKA, and 1 was hospitalized for HHS. Now, about half of all my patients report having at least 1 episode of hypoglycemia in the last 7 days. And they honestly would, when I would talk to them about this, they would report it to me as though it was normal. They're like, oh, it's normal. I have a low blood glucose. I've got 1 episode of hypoglycemia at least once a week. It's fine. And I explained to them, no, that's not a goal of this study or of this clinic. I don't want you having episodes of hypoglycemia. And then about a third of all my patients reported noncompliance with at least one of their diabetes medication doses within the last 7 days. So interim analysis for 28 of my patients. These are patients in whom I have baseline blood glucose levels that I can compare to follow-up. So what I did was I took the first 7 days of clinic enrollment and compared that to the last 7 days at the last follow-up visit. And at baseline, my patients were averaging at 215 milligrams per deciliter. At follow-up, their average was 159, and this yields a net reduction in about 56 milligrams per deciliter, or approximately 2 A1C percentage points. The average follow-up is 27 days for my patients. So I provided diabetes self-management education to all 35 of the patients in my clinic. I've initiated 47 medications, adjusted 73 doses, and discontinued a total of 11 medications. So as we can see, I've used a wide range of anti-diabetic agents, so insulin, DPP-4 inhibitors, GLP-1 receptor agonists, metformin. For primary and secondary cardiovascular prevention, I've initiated baby aspirin and also statins for some of the patients, and also for a couple of patients who had severely elevated triglyceride levels, we initiated a fenofibrate and also omega-3 fatty acids for some of those patients. Insulin, by far, is the most common dosage adjustment that's been made in the intervention period. This slide I'm actually really proud to report on because I've been able to get 6 of my patients off of insulin so far. One of those patients I actually is just managed on diet and lifestyle alone. The other 5 patients are on at least one non-insulin agent. However, this is something I am very proud to report on. So now we're going to move on and discuss a couple of patient cases. So the first patient we're going to discuss here is patient JH. He's a 58-year-old Caucasian male. He received a liver transplant on June 25th of 2013, secondary to alcoholic cirrhosis. He presented to our transplant clinic on February 25th for one of his regularly scheduled visits. He has a past medical history for type 2 diabetes that was diagnosed in 1998, so this is long-standing for him before transplant. Also, he has hypertension, hyperlipidemia, diabetic neuropathy, and obesity based on his most recent values. Positive family history for type 2 diabetes, and he is married, lives with his wife, and something that's very important to note here is that he works as a sales consultant, and he actually has breakfast and lunch meetings as business meetings, and this comes into play with his compliance here in just a moment. So his A1C, 10% at baseline. Now, his AST, ALT are elevated, and remember, this is important when choosing pharmacotherapy for our patients, and his fasting lipid panel was not at goal. So at the time of enrollment, he was on Levemir 50 units twice a day, and on Novolog 20 units 3 times a day with meals. His immunosuppression regimen consisted of tacrolimus 2 milligrams in the morning, 2 milligrams in the evening, and he was not on any steroids or an antimetabolite. Calculated his 10-year ASCVD risk score, which is 22.6%. So essentially, patients who have an ASCVD risk score greater than 7.5%, it's recommended that those patients receive a statin for primary cardiovascular prevention. So his is high, and he should receive a statin. Also, he's on an aspirin and ACE inhibitor for primary cardiovascular prevention as well. So something to note with this patient is that he reported virtually complete noncompliance with his Novolog regimen. As I said, breakfast and lunch, he had meetings as part of his job. And so due to social constraints, he didn't want to pull out his insulin pen and give himself his insulin, and he also didn't want to check his blood sugar either. He was also being non-compliant or non-adherent with his Levemir doses as well, too. He denied signs or symptoms of hypoglycemia. He endorsed signs and symptoms of hyperglycemia, so polydipsia, polyphagia, polyuria, also dry skin, dry mouth. He was not splitting his Levemir doses, and he was eating out the majority of the time, so a poor diet, and he was not doing anything in addition to, or any activity in addition to work. So looking at his blood glucose levels right prior to enrollment, as you can see, we've got several in the 500s for this gentleman. He was averaging 380 for his fasting blood glucose levels and about 450 for his evening blood glucose levels. So at the first clinic enrollment, or at the first encounter with this patient, we increased his Levemir to 60 units twice a day, had him split his doses 30 and 30 for each administration, and also had him rotate the injection sites. So we discontinued Novolog insulin. And I worked with Dr. Spieg and introduced the idea of starting exenatide for this gentleman, and we agreed on this. And we started exenatide, extended release, 2 milligrams, subcutaneous injection, once weekly for him. Also started atorvastatin 10 milligrams daily for primary cardiovascular prevention, reviewed healthy plate method for portioning carbohydrates, needed to provide education on what is contributing to high blood glucose levels in his diet. Also, we set a goal to increase activity level for him and reviewed the rule of 15s for treating hypoglycemia if it were to occur. So here are the follow-up numbers for this patient. So again, those are right prior to enrollment. Now, we increased his levometer to 70 and 70 and continued exenatide for him. Now, as you can see, we're starting to see some improvement here. However, I will note that after a week, he started developing nausea. So again, the third follow-up visit increased his levometer to 75 and 75. At this time, though, I had actually contacted Dr. Spieg and introduced the idea of starting metformin for him because this guy was definitely exhibiting signs of insulin resistance. And we agreed that it was a good idea to start metformin for him. And as you can see, after we initiated metformin, we're finally seeing numbers less than 200 for this gentleman. Now, one thing I will note here is that he kept reporting nausea, unfortunately. And this nausea would start the evening of his injections, and they would last all the way up to Wednesday or Thursday the following week, unfortunately. So on the 17th, we ended up stopping the exenatide extended release for him and starting liraglutide for him. Liraglutide is Victoza, and actually we've got many patients in our transplant clinic on Victoza, and they're tolerating it quite well, actually. Now, here's the follow-up numbers for this patient so far. His blood glucose at the last follow-up visit is, still above 200, but we got to reach that new baseline for him. We got to get him now to his new normal, which is going to take a little bit of time. We got to get the, he just started the liraglutide 1.8 milligrams on Wednesday, actually. But this is an example of some good numbers that we've gotten. So just to wrap up, JH, so he had a high baseline insulin requirement, and this is due to the fact that he has had diabetes since 1998. So his pancreas has endured some stress over the time, I would say. Now, the GLP-1 receptor agonists, I would say, as you can see, they've been effective. Okay. However, the thing I need to note here is that were we seeing a decrease in the blood glucose levels because he was experiencing nausea and he wasn't eating as much? Is it because of the effectiveness of the GLP-1 receptor agonist? It's likely a combination of the two. But just to be fair, note that metformin, as you can see, great insulin sensitizer, and we saw a improvement in his numbers after adding that. What's the role for a TZD? Remember, this guy has elevated AST, ALT. So again, I think just the concern right now is actually safety in our solid organ transplant recipients. And the key for this patient is close follow-up. That's how I've been able to actually get his numbers to where they've been. So now we're going to move on and discuss patient number 2, patient DR. Patient DR is a 43-year-old Hispanic male who received a living unrelated renal transplant August 4, 2011, secondary to FSGS. So he had reported to our transplant clinic on March 30th for an unscheduled visit. He had an ERCP scheduled the following day, but the week prior, he had actually been admitted to an outside hospital for hyperglycemia. So he was concerned about his blood glucose levels being high, so he wanted to stop by the clinic. And so he has a past medical history significant for IHBD, stenosis, status post stent, also with recurrent cholangitis. He's had multiple ERCPs, hypertension, hyperlipidemia. In the last 3 months, he was living in Brownsville, Texas with his family. Now, at this time, patient DR had endorsed increasing his tortilla intake, drinking beer, soda, pizza, sweets in his diet. He was trying to actually gain weight, but he essentially didn't realize he was eating the wrong foods. So he had endorsed polydipsia, polyuria, increased fatigue. He had denied nausea, vomiting, diarrhea, fever, chills. He had a point of care glucose that was 443 milligrams per deciliter. He had been started on metformin the week prior, 500 milligrams of the extended release formulation. However, nurses they couldn't get a good IV access in clinic for hydration for labs, so he ended up being admitted to our floor for hyperglycemia and dehydration. So now you look at DR's A1C, 11.9%. Also, his hemoglobin was 8.2, which could partially explain the fatigue that he had been experiencing. His creatinine was 1.3. Now, his creatinine had bumped up to 1.6 at an outside hospital. his baseline was about 1.2. And as you can see in orange here, his lipid levels are actually low, so we might have to adjust his atorvastatin dose here. Not started by me, that is. So at the time of enrollment, his metformin, or he was on metformin 500 milligrams, extended release daily. He had been released from the hospital on Levemir, 10 units twice a day. And his immunosuppression consisted of tacrolimus, 2 milligrams in the morning, 1 milligram in the evening, prednisone, 5 milligrams daily, no anti-metabolite. Now, I could not calculate a 10-year ASCVD risk score for him because his lipid levels are actually too low. And so he was on atorvastatin 20 milligrams daily, on lisinopril 5 milligrams daily, but not on an aspirin for primary prevention. So now looking at patient DR's numbers, so these are his numbers after, so on the 6th was our first clinic visit after he had been discharged from the hospital. So what we had actually, I worked with Dr. Edwards on this patient, and we had agreed to start liraglutide for this patient, 0.6 milligrams subcutaneously at bedtime. We continued to the Levemir 10 units twice a day, continued his metformin. Now, after we started that liraglutide, look at those numbers. We're seeing some effect here. We had actually decreased Levemir down to 6 units twice a day. However, DR started experiencing nausea, unfortunately. Follow-up visit. Numbers are continuing to improve. So we ended up going up to 1.2 milligrams of the liraglutide and decreasing down to Levemir 8 units once daily in the morning. Continued the metformin. Subsequent visit, I had the idea that we're going to be able to get that insulin off for this guy. So we went down to Levemir 4 units in the morning, but actually went up to metformin 1 gram ER once daily. And at our last follow-up visit, we were able to actually DC the Levemir. And due to the nausea he was experiencing, we actually had decreased the liraglutide dose a bit to 5 clicks past the 0.6 milligram dose to try to alleviate or help with that nausea a bit. And we actually continued the metformin as well. So now I would like to introduce patient DR. He's here with us today. One thing that I want to say is that one thing that resonated with me was the fact that at one of our follow-up encounters, David had said to me, he said, man, I've got to tell you that of all things I've been through, and this guy has been through a lot. I mean, numerous procedures. He said, being diagnosed with diabetes is the scariest thing that I've ever been through. And I'm like, really? Like, really? You know, and I just realized that I had become sensitized to this. And because I remember when I went and saw him when he was inpatient, and he was scared. And like, I just didn't really pick up on it. But the fact that he said, this is the scariest thing that's ever happened to me, I was like, you know what? This would be a really good opportunity for you to come and be a guest speaker for a few minutes at Grand Rounds. And so I'd like to introduce David Rodriguez, patient number 2.
Thank you, everyone. I know that I don't have much time, but I wanted to say that I love being in Brownsville. But at the same time, I've been wanting to go home for the past few years. The time that, you know, I was, many of you that are not familiar with me, my name is David Rodriguez. I used to be a patient navigator for University Transplant. And I started working 2 months after I received my kidney transplant, and I was on a roll. I mean, I just wanted to spread the word about transplant, be a patient advocate, and talk to everyone about our institution and what we can do better and all those things. And throughout 6 months after, you know, I was diagnosed with, there was a stone in my bile duct that didn't move because of my prior gallbladder removal. And then from there is when it started, my fevers and unknown fevers that I had. And so I went through all this process. It was really tough. I've been admitted to University Transplant about 24 times. I don't know how many days has that been, but it's been 24 times. I've gone through, I think this June will be my 16th ERCP. 13 here in the facility and 1 in Seton Hospital and 1 in the Valley. I've gone through numerous of x-rays, 39 x-rays, 10 MRIs. If I could go on and on the process, I had a liver tube on my liver for about 6 weeks. It was really, really uncomfortable. I had a hepatocolaginostomy surgery as well. So I've been gone through so much. And despite of everything, I resigned my work because I wanted to get cured and I wanted to be with my family. So I resigned and I was going to go home, but I still keep getting sick and I wanted to be close to the hospital. So after, completed 2 years, I was fine. So I went back home to be with my family and I got really comfortable. I got indulged with a lot of food. I mean, the tacos are not compared to the ones we have here. The tacos are really big. And I could eat those. I was eating those and 2 Dr. Peppers. And I mean, I'm a Dr. Pepper freak, not anymore. But other than that, I was feeling symptoms that I didn't know. I mean, it's like any other patient that you receive, you think it's going to go away. And I guess it's all about acceptance. It's about accepting the fact that, well, I think this is going to go away. Maybe I'll just drink a beer. I think that'll go away. So it kind of did, but it didn't work. And after that, I started getting symptoms of numbness on my hands and so forth. Until it got to a point where I just couldn't. And I called Dr. Juan Guerrero, and I let him know, look, I think it's my glucose is up. So he recommended metformin, and I started taking it. And the first 3 days I couldn't take it. So I went to the hospital, Valley Regional Hospital, and they gave me some units. I said, look, I have an endoscopy on March 31st. I need to get out of here. So we didn't give you enough units so you could drive. And so they did that night before. I woke up at 5 o'clock in the morning, and I drove myself over here 4 hours. And it got to a point that I couldn't feel my hands. I was losing my vision. I was going like this because I was seeing the same thing. I was blurred. So as soon as I got in, I spoke to PA Mark Denman, and he just said, you ain't going nowhere, buddy. You're staying. So I kind of knew because I already brought my clothes with me. So as soon as I got in, and March 30th is when I made David Newland when he came into my room. And of course, like any other patient, you get all this, I call it the dream team when they come into groups and stuff like that. So I always, here comes a dream team, see what they want. So David came by himself, and he introduced himself, and he told me, look, flat out, he goes, you're diabetic. At the same time, during those 2 years that it's well known that patients like myself, we're borderline sugar. So I wasn't really diagnosed with diabetes. So until he told me you're diabetic, that kind of hit me the most. I mean, the reason I told him that it was very scary because it runs in my family. It runs in my family. And just this year, I lost 2 cousins. I lost a cousin that was on dialysis and uncontrollable diabetes. And just this week, we just buried another one. So this comes a history of my family in the Hispanic environment in the Valley. I'd say, a lot of people, well, they were not in compliance. I said, no, it's a lack of education. It's a lack of education for them to follow. I think in my world, now that with this experience, I think if they would have had a David Newland over there, I think they would have been successful. They would at least have some guidance. They would at least would have some sort of hope. You know what? This could happen. So when I looked at David, and I said, what can I do? What I'm going to do is I'm going to meet you halfway. I said, you tell me what to do. As soon as he told me there's a light at the end of the tunnel where he said, you could be off of insulin within 3 months, I said, okay, I'm in. Just tell me what to do. And I changed my lifestyle. And when he said, well, your diet, I said, well, it's not really a diet change. It's more like a food consumption. It's to manage your food consumption because, but other than that, and when he says insulin, I remember the first time we said, well, you're going to get some insulin. And you always think syringes. And believe me, knowing my family, knowing the history, knowing what I see, and I thought, and then he brought a pen and he said, you know what, this is what you're going to do. Literally, I was at my friend's house, and I was there, and I pinched myself, and I was 5-10 minutes. I couldn't, like he mentioned, I've been poked so much, and I said, and I always joke around that I've been poked so much more than Facebook, because, literally, I had about 4 or 5 PICC lines. You can't find my veins. I've been on dialysis, 15 centimeters, injections, one this way, one that way, but I couldn't do a small needle. It was really difficult, but as soon as I did, I pinched so hard it didn't even feel it. So after that, I started, the goal was, for me to stay okay in about 2-3 months, and in about 3 weeks, I met my goal, and he took me off of insulin. And for me, is to follow the food consumption that I do, my change of lifestyle. It worked. I could tell you right now that I'm a true living product of David's work because of his guidance. And just in short, I think what the idea of what he did was sort of like follow the same protocol when you get transplanted first. When you get transplanted first, you go automatically to the clinic. And from there, they follow you for the following week. And then from there, they follow you. So they kind of like give you baby steps until after 2-3 months, hey, I think you're going to be fine. And I think that's what David did. I think what it was so amazing that he followed through. As soon as I was released from hospital, he gave me a call. He said, here's my cell number. If there's any changes, you call me. I did call him one time at 11 o'clock at night because my glucose was getting down to 72, I believe. And I was scared. I was already buying sneakers and orange juice because I said, I don't want it for it to go down to 70. He said, no, that's fine. But tell you what, just reduce your insulin and we'll talk about it in the morning. But to have that communication with him and to have that ability to reach out, any questions, anything that you think, I think it's a sense of comfort. I didn't have to use his cell number, but knowing that I had it on my phone, it made me feel so comfortable. But in the end, I just wanted to say thank you. And like I said, a lot of people, my friends, call me Super Dave, and I guess we have another Super Dave around the hospital because he's just an awesome guy, and I just wanted to thank you, give him a special thanks. Thank you.
Okay, man. Thank you. Okay, I did not pay him to say any of that. I promise you. But thank you very much, David. I really appreciate that. All right, we got a couple minutes left, and we're going to wrap up. So, what do these results tell us so far? Well, the results do suggest that a pharmacist-run post-transplant diabetes clinic can positively impact glycemic control in our solid organ transplant recipients. The key is tailoring therapy, or tailoring the pharmacologic therapy to the pathophysiology of the diabetogenic factors that I was speaking of earlier. Again, we have to monitor for adverse drug events for our patients. The concern with the GLP-1 receptor agonists, for example, is that they would cause profound nausea leading to vomiting, dehydration, subsequent prerenal azotemia, for example, and then you've got concomitant nephrotoxins or calcineurin inhibitors on board, and you can compromise renal function. The key, however, for all of this is close follow-up. The normal standard of care right now for diabetes management is follow-up every 3 or 6 months. And the key is actually following up closer, much closer for our patients. Challenges I faced so far have been a language barrier. I do have patients who speak Spanish primarily, and I will say that these encounters take at least twice as long. Also, patients who are not able to follow up with me, I'm hesitant to enroll them in clinic because I do like to maintain a constant contact with my patients. I want to make sure that, as David said, I give them my business card with my cell phone number and my direct office number on there. I've never been bugged by a patient. I just want to make sure that I'm available if they have questions. I do have one patient, for example, in our clinic who doesn't have a cell phone, and so we actually have him come in every couple of weeks for follow-up that way, because otherwise I would be following up with him on the phone for convenience. I have learned how to master time management with the rigors of my PGY2 residency project, or residency experience as a whole, with managing the patient load I have right now with this project. One challenge has been contacting providers for starting and stopping medications, ordering baseline labs, follow-up labs, for example. I do have one provider, for example, I will send her an email, and within minutes, I get a response, which is excellent. Thank you, Dr. Edwards. And then, then a couple other providers may take a little bit longer, up to a week to get back sometimes. But that can sometimes impact patient care a little bit with my interventions. I do have a couple of patients I would describe as being brittle diabetic. Those patients who are admitted for hypoglycemia, and then they're discharged from the hospital, and a couple days later, their blood glucose levels are in the 500s, for example. So for those patients, for example, it's okay to let their average blood glucose levels float in the 200s, because no blood glucose levels are okay for them. And the last challenge is going to be sustainability of this project. So what is going to happen afterwards? Future goals are to demonstrate, hopefully the final results of this project will demonstrate a positive impact on glycemic control in our solid organ transplant recipients. Ultimately, I'd like to justify 1 full FTE for a certified diabetes educator, transplant clinical pharmacy specialist in our transplant clinic to not only help manage chronic disease states such as diabetes, but also be there for transplant-specific pharmacotherapy issues that our providers might need assistance with. We could do this through creating a collaborative practice agreement where pharmacists can engage in collaborative practice or in disease state management under one of our providers. This would be an excellent learning experience for our future pharmacy residents and students, and this is one way for actually potentially sustaining the project. During my PGY1 residency experience, there were 7 of us PGY1 residents, and we were the ones that ran our longitudinal clinics. We had a diabetes clinic, we had a renal clinic, for example, and we, as residents, would actually run these clinics in conjunction with our primary preceptor, of course. And lastly, I'd like to publish the study and contribute to that positive data that I was speaking of. So the last thing I want to leave you with is just try to sit back and think for a second about how sensitized we've become to diabetes. I know diabetes is everywhere here in San Antonio, but when we think of the word diabetes, I don't think we oftentimes think of the other components or the other factors. So patients think, oh, I have a disease, I have a disorder. Is this destructive? I'm so destructive to myself. How is my food affecting this? What diet, for example? Just all these other needles. That's the biggest one. Some patients have needle phobia. And so these are all challenges that we have to overcome. With that being said, I would like to thank the following people. Pam Maxwell and Dr. Edwards have both been my primary cheerleaders in this project, so I couldn't have done it without them, and I absolutely appreciate it. I came to them with this grandiose idea of having a diabetes clinic, and look at what we've produced so far. Dr. Spieg, thank you so much as well for representing the GI team. He's been the attending he's my go-to attending on the GI team. PA Samuels and PA Dedman honestly have been instrumental in this because they have really trusted me and have called me constantly with new consults and are one of the ways I actually got patients enrolled here, and I absolutely appreciate it. Elvia has been amazing as well, too. Elvia has been in contact with me several days a week and sent me patients, to enroll in the clinic, too. So thank you so much, Elvia. You're wonderful. And Patricia Jones, I don't think she's here, but Patricia Jones let me use her director's office in our transplant clinic to see patients, and it worked out perfectly. And then lastly, David, thank you very much for coming and for such kind words. And that concludes today's round. Yes?
That was a great presentation and incredibly impressive work. You said at the beginning that you had created a treatment algorithm. Mm-hmm. Is it easy, complex?
So
essentially,
what I've done is I used the algorithm that's from the 2015 ADA Standards of Medical Care Guidelines, and so I actually have this. If I can access it real quick, I could show you. I have it as a hidden slide here. So this is the algorithm used. What is recommended and this is for the general population, of course, but what's recommended is for patients who are newly diagnosed with diabetes, recommend monotherapy with metformin initially. So what you are supposed to do per the guidelines is start a patient on metformin, you wait 3 months. If you're not getting a response, then you can progress to dual therapy. Now, dual therapy would consist of metformin plus any of the following agents. For me, based on my experience and the evidence that I do know in solid organ transplantation, TZDs, DPP-4 inhibitors, GLP-1 receptor agonists, and insulin are going to be the best agents to use in our transplant recipients. The sulfonylureas I do not recommend because what they're just doing is they're kind of overworking the pancreas. They don't have a protective effect. All they're doing is just stimulating the release of insulin. And so I would advise against the use of the sulfonylureas in our transplant recipients. The problem is that sulfonylureas are cheap. That's the problem. And the SGLT2 inhibitors I don't recommend because, look, we've got dehydration, infection risk, not good for our kidney transplant recipients, for example. Triple therapy, again, so what you would do is you keep going in 3-month increments. Triple therapy and then combination injectable therapy are recommended essentially for patients. So if you have a patient who has an A1C greater than 9%, it's recommended that you start here with dual therapy. And if you have a patient who has an A1C greater than 10%, what is recommended is you start with combination injectable therapy, which is where you use basal insulin plus mealtime insulin, which is preferred, or you use basal insulin plus a GLP-1 receptor agonist. You're not supposed to use a GLP-1 receptor agonist in mealtime insulin because the GLP-1 receptor agonist is going to be working to decrease postprandial blood glucose. So they're kind of going to, they could lead to hypoglycemia if used together. But metformin is recommended in conjunction with all of these. So to answer your question, what I did was I followed this algorithm, but just used my diabetes or my transplant-specific knowledge of the disease states to create my own algorithm that's kind of similar to this. Dr. Edwards. I appreciate that. Absolutely. Yes, Pam?
Excellent presentation.
Thank you, Pam.
So one of the things that you mentioned about your primary outcome, the A1C, hemoglobin A1C, is that there are caveats with that for patients that are less than a year post-transplant.
Yes.
And we had a lot of discussion about what we were going to choose as our primary outcomes, and it was decided that this had to be part of our primary outcomes because it is the gold standard. And obviously, in a 6-month project, it's going to be sort of, a limited glimpse at what it is that we're looking at. But I think it's going to be meaningful once we get the 3-month outcomes. But if you guys think back to Dr. Bronzo's presentation a few weeks ago, we see improvement for the first few months, and then we start to see those numbers drift back up again. And so I think the most important thing that we can emphasize here is that, yeah, we can show an improvement with that intense follow-up for a few months, but the key is going to be sustainability for us to be able to improve our long-term outcomes overall. So,
Absolutely.
good job. Well done.
Thank you, Pam. Jennifer?
So I saw Dr. Edwards' eyeball me. She asked her question. She had one eye on both of them. Two years ago, University Health System entered into a contractual arrangement with the hospital. What that, in essence, is revenue sharing between pharmacy and the hospital. And transplant centers that have gone into 340B partnerships is wildly popular. It's kind of caught on fire and trailblazed throughout the country. Had a plan for that revenue, and that plan for that revenue is to enhance pharmacy providers, and which would exponentially improve performance. And so it's been pretty frustrating that no one has engaged the transplant center in the benefits of 340B. No one's looked to reinvest those dollars in increasing our pharmacy or performance improvement or central authorization teams and on and on. So I really, and I know we had this discussion when this project first began, but I really think these are the types of results we can tie directly to a return on investment, to go to the hospital and say, you have funding to do this. You have the dollars to do this. So, I kind of guess I challenge Pam and David and Dr. Edwards to let's go eyeball the hospital and see if we can control that.
Excellent. Thank you, Jennifer.